બહુ ટાઈમ થયો ને.
બહુ ટાઈમ થઈ ગયો. હા.
We are going live on YouTube. Just wait for a minute only.
ચાલુ નથી કરતા.
કોકેલાબેન નમસ્તે. નમસ્તે નમસ્તે.
નમસ્તે નમસ્તે. બરાબર છે બધું? ફાઇન.
જગદીશભાઈ વાળ વધારે ધોળા થયા અને સફેદ કાળા થયા છે.
આજે વ્હાઈટ ડાય નથી કરી એટલે.
Okay, good morning. Welcome back to Saturday Club after a gap of 3 weeks because of Diwali. So happy New Year to all of you and hope all of you are doing well. So post Diwali, this is our first meeting and we have Dr. Aditya Sudhalkar, a young ophthalmologist, talking to us about vision after 40. So we are looking forward to some interesting things about vision after 40. To introduce Dr. Aditya, he is a young ophthalmologist practicing in Ahmedabad as well as Baroda. And he had done his fellowship in vitreoretinal disease and surgery at L.V. Prasad Eye Institute, Hyderabad, a very well-known premium institute in ophthalmology. And I was very impressed when I first met him during one of the surgeries of my close relatives, that he is very young and he's interested in a lot of research activities. So I was told by him that there is a massive data collection in his own hospital and he is trying to analyze them and present them. And apart from his own work, so to his credit, he has 57 publications in various leading international ophthalmic journals. He had several presentations at various national and international conferences. He is also faculty at minimal bulking surgery teaching course at Uveitis. So we have Dr. Aditya Sudhalkar, a very young ophthalmologist interested in research activity also. So over to you, Aditya. Your talk will be about 40 minutes or so, and then we'll have 10-15 minutes for discussion. So over to you.
Sir. Thank you. Thank you. A very good morning to everyone once again. And sir, thank you very much for a very kind introduction. Over the past 2 or 3 years, ever since I've been associated with this clinic in Germany, we have actually managed to accelerate our research because now we have a lot of access to German data as well. And we have had some very interesting collaborative projects. But without me wasting much time, let me just start off with my presentation. I hope the screen is visible.
Yes, yes. Well visible.
So this is a condition that affects almost everyone. In fact, I've had a similar lecture, I think 6 years ago at the same forum, I think in 2015, if I'm not wrong. But just that there are many updates over the past 6 years. And, fortunately or unfortunately, most, if not all people will touch 40. And this will eventually affect everyone. So visual loss, of course, the word itself doesn't necessarily mean that you have lost your vision permanently or but it just means that there are many changes that happen in the eye after the age of 40. It's not always a frightening situation. And, especially in a country like India, the first question is, can I pull on with this vision? So the good news in most cases is that, yes, the so-called visual loss does not always need intervention. So a classic example, of course, would be presbyopia, which I would be coming to shortly. So as is true for any medical condition, the patient profile, the history, travel, personal family history, the medication history, and the examination is relevant in these cases. So as would be true for any condition below or above the age of 40, vision loss can be classified either as gradual painless vision loss, which is the most common and the most frequent. Almost everybody has faced this situation of having to read at a distance, and this is of course known as presbyopia. So this happens due to a loss of the elasticity of the lens capsule. And the treatment for this is simple, just glasses, near vision glasses. Interestingly, people who have had myopia all their lives will slowly lose this number over a period of time. So if you have had glasses before 40, that is myopic, you have had myopia, you will slowly lose that myopia, and you will be able to read without glasses, say even up to the age of 60 or so, depending upon the grade of your myopia. However, people who have been emetropic or have had no glasses before the age of 40 will eventually need some correction for their near vision. And generally, what we do is we add plus 0.5 diopters every 5 years, which means say by 45 you will need 0.5 or 1 diopter, and it will continue to progress. There are now laser treatments available for presbyopia as well, that is for correction of this nearsightedness, or rather near vision issue that we have. But these treatments are not yet well established. So what many people prefer to do is, if they have myopia and they're touching 40, if they're very high myopia, let's say -8 or -10, what happens is you need vision, glasses for distance vision, but then you need, say, if you have -10, you will need -8 or something for near vision. So that is an extremely problematic situation, because then you have glasses both for near and distance, and you are virtually handicapped without your glasses. So what you can do in this situation is undergo clear lens extraction. It is similar to cataract surgery, but of course there is no cataract, and you replace your natural lens with an artificial lens, and that will at least eliminate one number. One advancement in this condition is the use of multifocal technology, which will offer you spectacle freedom over a wide range of vision. So the problem with multifocal lenses, of course, is that it reduces contrast and it reduces sharpness of your vision. Also, in some cases, it can cause dysphotopsia, which means you see halos or rainbow-like shadow over whenever you look at a bulb. So this can be very disturbing, especially at night. If you are, yes, sir.
Your slides are not moving.
No, sir, I'm not moving. Actually,
Okay.
I'm not. I just wanted to finish up presbyopia without going ahead. So, what it causes is, distorted vision, and it can cause glare issues, especially at night. So, if you're a frequent night driver, that can be problematic in certain situations. However, by and large, clear lens extraction has worked very well for people who have high myopia and who have crossed the age of 40. Of course, this option is available to even people who have not, had myopia all their lives. Even they have hypermetropia. So what it does is essentially eliminate this lens-related issue completely. And the other good part about this surgery is that this is a lifelong correction, as opposed to LASIK, in which case you will eventually get your glasses back at some point. So let's say a young boy or a young girl undergoes LASIK surgery at 20. They will develop presbyopia at 40, and they will need glasses. But once they cross the age of 40 and undergo clear lens extraction, that problem is taken care of. So the other issues, of course, glasses, the hypermetropic numbers, they go on increasing. The myopic numbers will decrease, but then you will have, glasses both for distance and for near. The most common cause of gradual painless visual loss, of course, apart from presbyopia, is cataract. It can also cause acute painful loss, but only if you let the cataract progress to an extent that it matures and then ruptures. The fourth, I wouldn't say common, but important cause of vision loss is glaucoma. And glaucoma is essentially it's a form of optic neuropathy. And the most common cause for this optic neuropathy is raised intraocular pressure. This is, of course, retinal detachment. In most cases, it can be acute, but in some cases, it can even cause gradual painless loss, especially if the detachment is an inferior retinal detachment. Another cause of gradual painless visual loss, which is very common these days, is diabetic macular edema, and we'll be elaborating upon that shortly. So these are other conditions. This is uveitis. The second photo is retinal vein occlusion. This is a tumor which is extremely uncommon, thankfully, in the pigmented races such as ours. That's a melanoma. And this is what we call a subluxated lens. That is a lens that has, lost partial or total zonular support. Now, acute painless loss of vision, as we just discussed, is retinal detachment, and the arrow points to a break in the retina, what we also call as a horseshoe tear, and that's because of this shape that we have. So this is the most common cause of rhegmatogenous retinal detachment, and the intraocular vitreous gel, which is liquefied after the age of 40, enters this space and causes a retinal detachment. This is optic neuropathy, or let us say papillitis, and this is vitreous hemorrhage and pre-retinal hemorrhage. So this can, of course, be caused by various conditions such as diabetic macular, diabetic retinopathy, or vein occlusions, or trauma, or even say a sudden spike in your blood pressure, which is, of course, more common after 40. So this is uveitis, and this is an OCT scan. This picture is an OCT scan. It's literally a CT scan of the retina, and this is what cystoid macular edema looks like. Now, cystoid macular edema is just a finding. It can be caused due to diabetes or vein occlusions, or even post-operatively in cataract patients. This is a very common cause of vision loss, especially 4 weeks after cataract surgery. Now, gradual painful loss of vision would include different conditions such as, say, insidious acute angle glaucoma, uveitis. Again, this is a second form of uveitis. And acute painful loss of vision could be something like endophthalmitis. What we see here is a large collection of pus, traditionally what we refer to as hypopyon. There is also some corneal component here. This is a corneal ulcer. The most common cause is trauma, but in this age of contact lenses, improper hygiene can also cause this. This is, of course, trauma to the eye, causing a tear. And this is a severe trauma, and actually trauma causing panophthalmitis, that is involvement of all layers of the eye with bacterial infections. So acute on chronic, of course, sometimes, you have insidious acute angle closure glaucoma, or let's say angle closure glaucoma, and then there's a sudden spike. Diabetic retinopathy per se causes painless loss of vision, but if it progresses to the extent that it causes neovascular glaucoma, you can have a sudden loss of vision. Uveitis, of course, we know that it is a recurrent problem, and it can happen at any point. I mean, we can have acute episodes at any point in time. And corneal dystrophies. So corneal dystrophies may cause continuous or gradual painless loss of visions, but sometimes they lead to epithelial erosions, and that cause pain. And of course, because of the anterior surface of the cornea is affected, it can lead to visual loss. Systemic illnesses and fever, chikungunya, dengue, we know that they involve the retina through their autoimmune processes at some point in time. Of course, these are very rare conditions, but still it is something that we need to keep in mind. Mind over matter, sometimes neurological diseases will present with visual loss. We have optic nerve diseases, papillitis, papilledema, tumors in the cerebral area, or occipital lobe problems such as hemorrhage. Anton syndrome is surprisingly common, they say. You have a bleed in the occipital lobe, and the patient denies any loss of vision, even when confronted with obvious evidence of his visual loss. So investigations would, of course, the first important examination is visual acuity, and what we refer to as best corrected visual acuity. both for distance and for near. Clinical examination begins with an overview of the lids and the ocular surface. And then we have the pupillary examination. That is the most important step before dilating the pupils. So except for the pupillary reaction, everything else is best assessed through a dilated pupil. The only exception would be in suspected acute angle closure cases, where dilating the pupil can actually exacerbate a spike, and that is something that you would want to avoid. Special investigations, there are tons of special investigations that are available now for the eye. The eye, as we know, is constructed in a way that we can look into it without actually invading it. And, it's designed like a camera. And therefore, all special investigations take advantage of this particular, this principle or this privilege that we have. That can range from something as simple as fundus photography, just to look at the retina, to fundus angiography, to OCT scans that will be coming to shortly. And then there are many optic nerve assessment tools as well. We often refer patients to neurologists for VEP scans. And then there are specialized investigations such as the electroretinogram or the electrooculogram for diagnosis of different dystrophies. That is more relevant in the younger population because they generally tend to manifest by the age of 40. But there are certain conditions such as even retinitis pigmentosa that manifests very late. Systemic investigations based, of course, on your findings in the eye. It is not uncommon to diagnose diabetes based on ocular findings, because the patient is completely unaware, and then they come with perhaps vitreous hemorrhage. That's, of course, a very late stage of diabetic retinopathy. References to physicians at every step of the way is important. Even for something as simple as cataract surgery, it is not advisable to proceed without physician clearance. So therapy can include medical, even ocular and systemic therapy. It's not uncommon for us to start steroids for a variety of conditions, ranging from trauma to uveitis. Laser therapy, typically, for the layman, laser, everything in the eye can be sorted out with laser, be it cataract surgery, be it a retinal detachment, everything. So the first question that patients generally tend to ask is laser thi thasen. So this is of course a misnomer, or let's say this is a rather misinformation, because in fact laser therapy for cataract surgery has been tried and has not been as successful as phacoemulsification, which is based on ultrasound. But anyway, that's a different story. Cryotherapy, we apply cryotherapy especially for retinal conditions, and it is also very useful controlling absolute glaucoma, that is glaucoma in a blind eye, and which cannot be controlled by surgery or any other means. Surgery, of course, is the final option ophthalmology is largely a surgical branch, but there are also many medical conditions, or rather conditions that can be treated medically. So apart from presbyopia, the second most common problem is cataract. And this is one standard of care is now phacoemulsification surgery. There are advancements in that, and that one of these advancements is laser-assisted femtosecond laser-assisted cataract surgery. And essentially what it does is it eliminates the use of the knives, that is the keratome and the side port incisions that we make for the surgery. So we can see that this main incision is made by a 2.2 millimeter knife, and this second instrument, this probe or this chopper, has been introduced to a 1 millimeter incision. So that is taken care of by laser. For an experienced surgeon, it doesn't have such a big advantage, and that is the irony of the whole thing, that people who cannot afford it need it the most. The initial people who are in the initial stages of their practice, and the experienced surgeons can achieve this without causing extra astigmatism, without causing much damage to the cornea, and they don't need it, but they can afford it. The third most common condition, or the third most known condition, is glaucoma. So in the past, glaucoma was synonymous with elevated IOP. There were no other factors considered. Now we know that there are many other factors, such as circulatory disturbances, that can either cause or exacerbate what we know as glaucoma. So high IOP meant glaucoma in the past. Then it began to be defined as an optic neuropathy, with IOP being the main factor. And now, with advances in technology and techniques, optic neuropathy along with visual field loss is what we define as glaucoma. So just having high IOP would simply be referred to as ocular hypertension. But if you can prove that it is associated with optic neuropathy or visual field loss, we would call it glaucoma. So this is 64 million people worldwide are affected, and this is expected to increase to over 110 million in the next 20 years. It's a big problem in India because it is, in most cases, it is undiagnosed. People either don't have access to an ophthalmologist, especially in the rural setting, or they simply don't want to turn up for an examination. In fact, I would rate both of these factors as equally important, because in India, the general mentality is to avoid going to the doctors as far as possible, even if you're insured. So this is, the general journey, if we can call it that, right? From, there is lack of symptoms during the early stage, lack of awareness. What it does is actually reduce your peripheral vision. So unless you are very observant, you will not notice this in the initial stages. It's only when you start bumping into objects while you're walking that you realize that there's something wrong. So a person can have 6/6 vision, but his peripheral field can be reduced to what we call as tunnel vision, as if you're looking through those horse clamps. So the most common problem in glaucoma is poor compliance, especially with medicines. Now, the good news about glaucoma is that 90 to 95% of cases can be handled simply with drops. And now with advances in medicines, that can just mean 1 drop a day for many people, or maybe 2 or 3 drops in the entire day. It need not affect your work schedule. You can instill them before you leave for work, come back and instill them. And many medications, such as prostaglandin analogs, need to be instilled at night, so just before bedtime. So that's not a problem. It's the continuity of therapy, not unlike diabetes and hypertension, that irritates patients. So why is it important? Because failure can lead to reduced treatment effectiveness. It can increase complications such as field loss, and then, of course, poorer outcomes. So one important step, especially in glaucoma treatment, is the use of fixed dose combinations. And because, multiple medications would mean multiple dosing schedules, and these medications eventually affect the ocular surface. They cause dry eyes, and that itself becomes a problem then for the patient. So now we are now veering towards what we call as preservative-free therapy. And especially in countries like Germany, the standard of care is pipettes, where you open one pipette and it lasts you for a day. After 24 hours, you throw away the pipette. But the good thing is it is preservative-free. So at least that part, the ocular surface irritation part is taken care of to a large extent. So I won't go into the details of therapy because that is a lecture in itself. But briefly, we have prostaglandin analogs, we have beta blockers, we have alpha agonists such as brimonidine, and then of course we have dorzolamide and brinzolamide, which are the topical variants of acetazolamide. Now, this is, let's say, another very common problem, and that is age-related macular degeneration. So what we have here is a clinical photograph of the fundus, and this pigmentation that we see, that is the earliest sign of age-related macular degeneration. This is an angiographic sequence, fundus fluorescein angiography, and what we see here is an area of hyperfluorescence. So that is the area of what we call as wet AMD. So AMD can be broadly classified as dry AMD, which just shows pigmentary changes and the appearance of drusen. So if I go back, there are, I don't know if it's clear there, but there are certain yellow spots here that we can see here. They are pigment epithelial changes, and they can eventually progress to drusen. Drusen is an accumulation of degenerative material underneath the retina or in the subretinal space. Now, this is again an OCT scan. And what we see here, this is from our German center, and hence this the German notations. But what we see here is, so this white line that we see here is the RP layer, and this is the retina. So this AMD or the new blood vessel formation, wet AMD, generally occurs either in the subretinal space or in the sub-RP space, or it can involve both spaces. So anyway, the treatment has now changed from photodynamic therapy, which was the standard of care in the 90s, to thermal lasers, and now to intravitreal injections. So the most commonly used drug for this condition is an anti-VEGF or anti-vascular endothelial growth factor injection. And now there are a variety of injections available. The most powerful or the most recent amongst those being a molecule called brolucizumab that has been released, say, about a year or a couple of years ago. It is extremely powerful, and it can help even patients who have not had therapy for a few years. At least anatomical results are fantastic. Vision would depend, of course, on the retinal integrity, and this is something that is affected through AMD. This is diabetic retinopathy, another condition, another common cause of vision loss after 40. This clinical photograph shows us multiple hard exudates and soft exudates. You can see this color change here. This is the macular edema, and this is borne out in this OCT scan. Apart from anti-VEGF therapy for diabetic retinopathy, another important implant that we have is a steroid implant called the Ozurdex implant or the dexamethasone implant. So this is a sustained release implant that can take care of this macular edema over 3 to 6 months. And if the patient presents early, what we have seen is that up to 2 years, sometimes people just need one implant. Of course, that depends on a lot of things, but we know for sure that once diabetic retinopathy sets in, only 11% of patients, or maybe say 12% of patients, will actually benefit from systemic control of the disease. So there is a strong genetic association with it. That does not mean, of course, that we don't advise them systemic compliance, because if nothing else, it can prevent the other form of diabetic retinopathy, that is proliferative disease, which in some cases is even more severe or rather dangerous condition, because that can definitely lead to complete blindness. Now, this is just a video on how we implant this this Ozurdex app, and that is the applicator going in, and that's the implant going into the space. This eye, of course, was pseudophakic, that is, has just received cataract surgery, and nowadays we can combine the two procedures. Diabetic retinopathy can also require surgery in some cases. This is a case of vitreomacular traction. I'll just go back and show the OC. We see these two lines here. That is the vitreous that has detached incompletely from the retina and has caused traction here, leading to visual loss. This is a normal scan. Actually, this is not a normal scan, but this is largely normal. In this, the scan to the right is one of retinal atrophy, but this contour that we see is more or less a normal one. So in this case, we have to actually go very close to the retina, and we have to remove this vitreous layer. So what I'm doing is trying to go underneath, under the posterior vitreous layer, the tenting that we saw. We use a special stain to make it a little more visible. And then we actually peel it off, just as we would say the skin on top of a tomato. Here it is important to make sure that you don't pull the retina while you're peeling, because what happens is it can cause de-roofing, and that can lead to further vision loss. So this yellow clump that we see here is a collection of hard exudates. This was a one-eyed patient. This was the better eye. And what we needed to do is remove not just the vitreous, but we wanted to ensure that he does not need further injections, because obviously, because he was one-eyed, he was very apprehensive about further treatment. So once you remove the vitreous, it largely takes care of a lot of your problems, especially diabetic macular edema. This is post laser after surgery. This is a severe case of tractional retinal detachment. An important cause of visual loss is diabetes. So here there is a fibrovascular proliferation on the posterior hyaloid surface, and there is a potential space between the retina and this proliferation. So you have to go on top of the retina and just peel off this proliferation. So that is what we are trying to do here. And what we see here is that we have gradually removed it in certain areas. Vein occlusions are also very common, and the most common cause for vein occlusions are uncontrolled hypertensives or fluctuating hypertensives. Again, there is a genetic component to it, so even well-controlled hypertensives can unfortunately suffer this problem. So this is what it looks like. This is a clinical photograph. We see this large clump of hard exudates here, but we also see this occluded vessel here inferiorly, and that is the occluded vein. So this leads to stasis and outpouring of exudates, and they go and settle in the most dependent part of the retina, that is the macula. This is an angiographic sequence just showing both the blocked area, and this is an important tool for assessment here in vein occlusions, because one of the things that we want to rule out in this case is ischemia and macular ischemia. Why? Because that can severely compromise your final outcome. So you can have a case of macular ischemia with macular edema, but even if the edema resolves, the visual gain will not be very significant. So in this case, there was no macular ischemia. So we decided to proceed with therapy. This is what the OCT look like. So the top scan is the normal eye, that is the right eye. The left eye shows a very obvious collection of fluid here. And these hyper-reflective dots that we see here are the exudates that we saw in the clinical photograph. So after we put in this steroid implant, of course, we can treat with this with anti-VEGF as well. We see a considerable reduction. So this is the top line. The top photo is the baseline one, and the bottom photo is say 1 month after the Ozurdex implant. This is 3 months post Ozurdex implant. The patient came to us with a vision of finger counting 2 meters, and eventually it improved to 618. She needed cataract surgery down the line, and now her vision is stable between 618 and 624, but quite a step up from the counting fingers 2 meters that she came to us with. So these are just, this is a continuous, we have, I just put this patient up because now we have a 6-year follow-up for this patient, right, from 2015. So uveitis is another common problem. It often affects the younger generation, but it is also associated with rheumatoid arthritis. It can be associated with ankylosing spondylitis, tuberculosis, and a host of other conditions. It is actually a systemic disease with an ocular manifestation. So even conditions like the Vogt-Koyanagi-Harada syndrome, where you have largely an ocular component, there is an affliction of the skin as well. So all of these conditions need to be treated in concert with a physician. For something as simple as starting steroids, it is important to get physical or rather physician approval. So this patient was diagnosed as diabetic macular edema elsewhere. And here we have this clinical photograph, we have these exudates, but we also have this reddish hue here. And it will become evident during the fundus angiography, which area actually has these uveitic patches. So uveitis is essentially in the posterior segment is also choroiditis, that is inflammation of the choroid, either the entire choroid or patchy inflammation. So these hyperreflective areas that we see here are the areas where we have this choroidal inflammation. It will be more evident now. And this is what it looks like. So all of these inflammatory conditions will eventually lead to macular edema. Now, the interesting thing about macular edema is it will always respond to systemic steroids, even diabetic macular edema. It will throw therapy from the systemic component to the local area, that is through these steroid implants. So this patient responded very well initially to steroids, and she eventually received the implant because her sugars were escalating beyond control. This is a case of endophthalmitis. This can happen after cataract surgery. So the primary thing here is use of disposable equipment, because if you're re-sterilizing something, you have to be extremely careful. If you use disposable equipment, by God's grace, touchwood, we have rarely, in fact, we have almost never seen an endophthalmitis case in which disposable cataract equipment was used. So just checking, do I still have time? Sorry, sir, you're on mute.
We have time. Please go ahead.
Okay.
You can talk for 10 minutes more, and then we will have 10 minutes.
So this is just a couple of slides more. So that's about it. Now, this is just a photograph of the implant. You know, we have been talking about the Ozurdex implant all this time. This is an intraocular photograph of the implant in situ. So we have put the implant in, and this photograph was taken through an indirect ophthalmoscope. So now we have video indirect ophthalmoscopes. I've just marked out the area just for easy reference. This implant generally stays behind the lens and in front of the retina in the vitreous cavity. Its position is important within the cavity, because if you know, during injection, if it is misdirected, it can go and hit the lens, or it can go and hit the retina. It is a very soft degradable poly. It's generally polyethylene glycol and polypropylene. You know, it's called a pegylated dimer. So it will not actually cause major problems, but it has been known to cause retinal breaks, just because, you know, when you inject it inside, it can go and hit the retina, especially in cases where you have liquefied vitreous. So the second reason why the position is important is steroids can lead to IOP rise, that is intraocular pressure rise. And we have done a study where we managed to show that the closer the implant is to the pars ciliara, or the ciliary body, the higher the chances of an IOP spike. So when we direct the implant inside, we try and aim for the middle of the vitreous cavity, because that is the safest place. The exact position of the implant would depend upon how solid the vitreous gel is. After 40, what happens is it generally tends to liquefy, and it gives rise to what we know as floaters. This is a very common problem. You know, you see these black dots moving in your visual field, especially if you look at the sky. In 99% of the cases, they are harmless. Only in 1% of cases, they can be associated either with bleeding inside the vitreous cavity, or it can be associated with a retinal tear, in which case it would need immediate attention. So we get a lot of patients. I mean, of course, it is very frightening to see these black dots in your visual field. And then we do a retinal examination. And then we generally, what we do is we call them back after 3 weeks. So this again is very common after 40, because that's when the vitreous starts liquefying, and that liquefaction leads to formation of these black, or rather opacities in this rather transparent gel, and that is what we see as black floaters being projected, because that is where light is obstructed. So they move with your eyes. If you look to the right, they can either move in the same or the opposite direction. And generally speaking, the musky volitans, as we call them, they will never interfere with your work. It is only when you are idle that you actually notice them. But for some people, it can be a very big problem. I mean, we have had patients who have had suicidal thoughts just because of this. So we generally tend to assure them, we just need to reassure them that this is nothing serious. You will eventually adapt to it through, through neurological adaptation. But just tiding over those 6 months or 3 months or whatever time it takes for that neurological adaptation can be very disturbing for these patients. Now there are new medicines available. There are vitreous and vitreous supplements, so to say, that can be taken orally. And the other thing that can often help in this musky volitans is the use of topical NSAIDs. So there are now newer formulations available. You just need to instill them once a day. And this can be supplemented with oral antioxidants and amino acids, the constituents of this vitreous gel. Interestingly, it is this liquefaction of the vitreous that gives rise to cataract, because the purpose of the vitreous is not just to fill up the vitreous cavity; it is to prevent the high, the high oxidative energy molecules that are, or the radicals that are flowing through the retina from reaching the lens. The lens, as we know, is avascular, and one of the important functions of the vitreous is to keep these oxidative radicals that are flowing through the retinal blood vessels from reaching the lens through transaxle. So once the vitreous liquefies, this process is, this barrier is broken, and that is why these oxidative radicals can actually reach the retina and cause age-related or senile cataract. So I will end my lecture here. Thank you for your patience, and I would love to take questions.
Yeah, thank you, Aditya. You can stop sharing. Great. So it has been a wonderful overview of various conditions which can impair vision beyond 40 years of age. So we have all benefited with this knowledge. Some of the things we knew and some of the things are new to us. So thank you for this good comprehensive talk. Now the house is open for discussion. Any questions, comments? Yeah, Sumukh bolo.
Okay.
Any comments from Pradeep Bhai? Pradeep Bhai, you are there.
Aditya, you advised that at around age of 40, lens can be replaced. Now, one of the complications of putting a lens after cataract is developing a fibrous layer on the lens.
Yes.
How often it happens if you put the lens at age of 40?
So, sir, this procedure is generally advised for people who have very high numbers. Now the newer lenses that have come out, they either delay or, in some cases even prevent the formation of this fibrous layer or posterior capsular opacification. Now, of course, in young patients, it is commoner to have this posterior capsular opacification because the lens fibers are extremely active. We remove the cataract, but there are microscopic, lens epithelial cells that generally tend to stay behind. With the newer lenses, we generally what we see is that if PCO or posterior capsular opacification, if it has to happen, it can happen even after 5 or 7 years. With the older generation lenses, this was a very common problem, and let's say it would happen in the first couple of years as well. Thankfully, this posterior capsular opacification can be handled with simple ND arc laser, and we create a small opening, and that takes care of it in most cases. Very rarely, if it is extremely fibrotic, which is not common after the age of 40, we need to remove it surgically. However, in pediatric patients, it is an extremely common problem. In fact, we have to assume that every patient will develop posterior capsular opacification. Below the age of 40, it is extremely common, let's say. But after the age of 40, many patients get away with it even without having to undergo additional procedures.
There is a question in the chat box from Dr. Sheetal Desai from Bangalore. Can you touch upon GCA leading to sudden vision loss?
Yes, sir. So, giant cell arthritis, it's common. Traditionally, the patient presents with sudden, temporal arthritis or something, and that can cause. So the treatment of choice here is, of course, steroids. But in many cases, this is, of course, in consult with a physician if they see anything. In many cases, this steroid therapy needs to continue for a very long time. And we use minimal doses, even 5 milligrams or something, because this can lead to recurrences. And it is a very nasty disease. It can, affect other areas of the face and the eye as well. So, but with newer immunosuppressants coming in, even they are very useful. We have azathioprine and methotrexate, which we have tended to use quite commonly. Again, in consult with a rheumatologist or an immunology expert. But yes, the treatment of choice is generally steroids. Even local therapy has been tried in certain cases in and around that. But more or less, we generally tend to treat it just with steroids. Oh, her father is a patient and he's been treated at the LV Prasad Eye Institute. So I don't know what regime they have advised there, but generally we try and bring it down to maybe 5 milligrams of steroid every alternate day. And we prefer to continue it for at least 1 year after the last attack. Thank you so much. Thank you.
Dr. Pradeep Bhai is here. Would you like to make any comments, Pradeep Bhai? Pradeep Bhai has been actually doing a lot of promotional activities for making people aware about diabetic retinopathy. through platform of IMA also. I've seen him working in this. Pradeep, are you there?
So good morning, everybody. Actually, I'm sorry I joined late and a large part of the talk I missed. And with Aditya on the floor, he is a prolific web.
No, sir. Thank you.
Netizens. Hardly any rejoinders needed. So, but to ask Dr. Sheetal what exactly her father had in the eyes, can you tell Dr. Sheetal?
Yeah.
Yeah.
So around 2018 March, he started losing vision in one eye. He lives in Navsari. So multiple doctors at Navsari, Surat, we showed everybody, but they said they couldn't diagnose actually.
Yes.
Then after about 10 days, he started losing vision in the other eye also. That is when I contacted somebody in Hyderabad, and I went to Hyderabad. They came from Navsari to Hyderabad and in LVP. But somehow, luckily, one loading dose of IVMP was given at Navsari before they started the journey.
Yes.
So
Yes.
by the time he reached Hyderabad, he had started regaining the other eye vision to some extent. But the first eye vision was gone 100%.
Yeah.
And later, they just had to give it for 3 days that IVMP 1 gram per day, and slowly they reduced it. And it is about three years now. He's on only very small amount of steroids, and he's doing fine otherwise.
Yes. Yeah. So actually, the GCA induced actually causes ischemic optic neuropathy, and it is of an acute type, and quite often bilateral if not diagnosed in time and managed in time.
That's what happened actually. First, we had good 10 days, but we lost those.
Yeah. So.
But anyway, the other eye vision also had started going away, but somehow it has kind of, we have regained, kind of it is good enough for him to live.
Yeah, yeah. So and to prevent that vision from being lost again with a relapse, GCA can have relapses, and so that's the reason this low dose of steroid on the maintenance. The immunologist would certainly help you with that.
So he is under Dr. Shweta now, rheumatologist and immunologist, and luckily he's doing well, and he doesn't have any other comorbidity, and he's fine. He's 78 now.
Yeah, yeah.
But he's completely okay now. I'm thank God for that.
Yeah, so you should be continuing with the steroids, as long as
Yes, sir.
the advice. Yeah.
We had horrible time. That was like,
it's good to
can't
know
even
that
imagine.
No, it's a very nasty disease, madam.
Yeah.
And then, we can either do a magnetic resonance angiography just to identify the area. So any unexplained vision loss, MRIs often help. So
we did that temporal artery biopsy also, and he's like Pakka GCA only. Probably we need awareness amongst ophthalmologists also about this disease. It's not very common in India, but nowadays it is common. I think in LVP we had multiple people over there getting treated for the same thing. And in fact, I slipped into depression after this, but somehow I'm also okay now.
Good. So that's the beauty of this Saturday club, Sheetal, because often my elder brother tells me that, Satish, you are a pediatrician, but you know a lot of things about other branches also, little bit at least. And that is thanks to this Saturday
I actually
club.
kept on studying once I came to know about this. And in fact, I only guided them to, I shouldn't be saying this, but I told them, please look into GCA. They said, no, it cannot be GCA. And like I was pleading and crying to what to do. Then when he came to Hyderabad, then things finally started getting sorted.
Since we are on GCA, one more comment here is that, GCA can present as a diplopia very early.
What he had, sir, is terrible tenderness while combing the hair.
Yes, that the headache and the frontal, yes, tenderness.
Then he had some pain near cervical, this thing. So they went to orthopedic. I'm in Bangalore. I didn't know. Actually, I couldn't do much initially.
Yeah, so I mean, this discussion is so useful for everyone who is listening in, and the real probably application of this club, that we come to know of all this, and at some point maybe we might be able to help somebody.
Becomes very helpful.
Yes, sir. It's truly.
Thank you for this discussion.
Thank
Any
you,
other
sir.
comments from
Yes.
any other member?
So just one quick thing, trigeminal neuralgia and GCA. Sometimes they can have overlapping things. So just because, but this is because it can, trigeminal neuralgia will not present with claudication or anything. But the other, scalp tenderness or tenderness while shaving, that can sometimes be, an overlapping symptom. So just something that needs to be looked at.
So thank you, Aditya, once again for this wonderful discussion.
Thank you, sir. Thank you for inviting me. Thank you for having me over.
Always welcome.
Okay.
And so thank you all for attending this meet. Next Saturday, we have Dr. Hemant Antani, who had been a speaker earlier also in our club. He'll be speaking about recent advances in medicine. Some very exciting things are happening, and he's going to elaborate on that. So we'll be back next Saturday. Thank you. Thank you all for joining.
Thank you, sir. Thank you very much.